Welcome to London Valves 2024. My name is Philipp Lurz from Mainz, and I'm here with Lukas Stolz from Ludwig-Maximilian University in Munich. And we came together today to discuss an important topic in the field of transcatheter tricuspid valve interventions, which, despite all the success we had, is still a clinical need in an area where we would like to improve. And that's the topic of residual tricuspid regurgitation. Lukas, how often does that occur?
Well, thank you, Philipp. It's a great pleasure being here with you today. Actually, it's a very relevant topic, and I think we have to differentiate between data we know from clinical randomized trials and data we see in everyday clinical practice. So in Triluminate at 30 days, we had about 10% of patients remaining with relevant residual TR, which means severe, massive, or torrential after the procedure. And in real world, data are ranging between 10 to 20% in large registries like BURIDE, PASTE, and EuroTR.
Yeah, it's interesting that in our randomized trials, the outcome was a little bit better, but I guess there's just a difference between a very controlled setting of a randomized trial and the clinical reality where sicker patients in more complex anatomies are treated. So 20% patients with residual TR, what are the implications for outcome?
Yeah, that's an excellent question, and I think we have to differentiate between mortality outcomes and symptomatic outcomes. We know from the field of tricuspid intervention that we mainly at the moment know that we improve quality of life. If we look at data from real-world registries at the moment, we've seen that there is a huge impact on mortality, whether we reduce TR to below moderate or mild, or we remain with severe TR. That's in line with results from the clinical trials. But we did not observe any survival differences in terms of 2-year mortality when comparing moderate and mild residual TR. But that's only valid for survival prognosis. If we have a look at Triluminate, for example, they have shown that the degree of TR reduction significantly correlates with the degree in KCCQ improvement, so quality of life improvement. The same we're seeing in registries. The degree in New York Heart Class improvement also correlates with the degree of TR reduction. The same has been reported for 6-minute walking test distance. The more we reduce TR, the better 6-minute walking test distance results are after the procedure. And finally, we've also seen that right ventricular reverse remodeling is more pronounced in patients with a more pronounced TR reduction.
Okay, that's important. So we can still hope for good clinical outcome even if you're only able to reduce it to moderate, but we should always aim for perfection. The less, the better it seems. And there is a clear, as you said, a clear association between the quality of the procedure and the clinical benefit. So it is important. What do we do with that now? How can we reduce these 20% of residual TR even further?
Well, I think we have to improve our understanding of tricuspid regurgitation in general. Patients we are treating in everyday clinical practice, they are very heterogeneous. We have atrial tricuspid regurgitation, we have pacemaker-induced tricuspid regurgitation. So if we have a look at the literature which try to predict residual TR, those predictors are very heterogeneous, probably due to not only different patients we are treating, but also due to challenges in tricuspid regurgitation quantification, especially after the procedure, once the devices are in place. That's one of the most challenging conditions for imaging nowadays. So I think we have to improve our imaging, especially after the procedure, in order to really quantify residual TR, maybe also having a look at CMRs. That's something we could do. And then we try to discuss every patient on an individual patient level in the heart team in order to try to predict residual TR in an individual case. And if
the procedural outcome, you mean?
The procedural outcome,
Yes.
Yeah. And once we're ending up with the opinion that we are not able to reduce TR in an adequate manner, we should also think about different treatment techniques we have available today.
Fantastic. So I think we can be proud of what we have achieved given the early stage of the therapy in general. The procedure is relatively safe and we do achieve good outcomes already in a high percentage of patients, but obviously we want to always aim for the best. We want to improve imaging. We want to make the best out of a group learning to improve the procedure, the strategy, the imaging, but also improve our understanding of how to decide who should undergo repair and who should undergo replacement. So a lot of things still to improve in the future, but as a group, we will succeed. Thank you.